You're live.
Good evening, all. Welcome to iFocus Online, episode 345, the 20th in the Oculoplasty module. Today, we have with us Dr. Rolika Bansal from Wills Eye Hospital, Philadelphia, USA, and Center for Sight, Hyderabad, to speak to us on embryology, applied anatomy, and physiology of the lacrimal system. It is indeed a matter of great privilege and joy to share our screen today with Dr. Rolika Bansal, with whom once we shared our coffee and space in Hyderabad. She has completed her MBBS from Kasturba Medical College, Manipal, Karnataka, MS Ophthalmology from KLESH, Belgavi, Karnataka, and stood first in the university for the same. She has a fellowship, ocular oncology and oculoplasty under the mentorship of Dr. Santosh Unavar, Center for Sight, Hyderabad, and currently is a fellow in ocular oncology at Wills Eye Hospital, Philadelphia, under the mentorship of Dr. Carol Shields. She is a recipient of 44 awards in ophthalmology, both national and international levels. She is a travel grant winner for ISOO 2022, WOC 2022, APAO 2023, STS ICMR grant in 2012. She has to her credit 48 research projects, including 2 clinical trials, 47 publications, of which 32 are indexed, and is an author for 3 book chapters. She has attended and presented research work at various national and international conferences, and is a mentor and a guide to most, if not all, sitting on this platform right across the screen, sharing her space today. And we welcome Dr. Rolika Bansal to present her talk today.
Thank you so much, Subha. And that's very kind of you to say all those words. And of course, yes, it feels odd to be on the other side. And thanks to Dr. Vanavasa for this opportunity to speak on this very interesting topic. Let me just set this up 1 second. So my screen is visible, right?
Yes, it is.
Okay. So through this presentation, I'll be taking you through the embryology, anatomy, and physiology of lacrimal system. And we will be taking them one by one. But just before I begin the entire in-depth introduction, let's just take a brief look at this. So basically, the basic anatomy includes the lacrimal gland. Of course, you all know there's an orbital part and the palpebral part. And the second component is the puncta. Over here, you can see these are the which are opening over the lacrimal canaliculi and the lacrimal sac and the nasolacrimal duct, and which is the opening of nasolacrimal duct in the inferior meatus. This is just a brief part, just to make you aware of what we're talking about. So I will not be talking about the secretory component, and I will be just talking about the drainage component of the lacrimal system. So to begin with, let's talk about embryology. So embryology starts basically by, just a second, it's on hold. Yeah, can you see my screen now? Subha?
Yes, we can.
Okay, sure. So 4 by 5 weeks, that is of the embryological development, we have the nasal placoid developing and the optic vesicle developing on either of the sides, the maxillary process of the first arch, the first pharyngeal arch, the second, third, and the fourth pharyngeal arch. So it's important for you to be able to understand these components because this is how we're going to grow further. And the oropharyngeal membrane, which eventually disintegrates. So as we go on, the 5th or the 6th week, which is the crown rump length of 6 millimeters. Over here, the frontonasal process develops, and the first pharyngeal arch, the maxillary process, they become prominent and they start growing towards the frontonasal process. As you can see, that the naso-optic fissure has a medial component and a lateral component that is called the nasal eminence. And the oropharyngeal membrane, which was disintegrating, is getting converted into a stomodium. And eventually, gradually, the second, third, and the fourth pharyngeal arch are going down. I know this topic is considered pretty extremely boring, I agree. But at the same time, what you need to understand is if you are able to fixate on the important terms, the important words, you will be able to put across in your examinations as well. And this is the 7th week when you can see the first pharyngeal arch. Now the maxillary process has started growing upwards, that is towards the caudal end, and this is towards the cranial end and towards the frontal process. And this is the naso-optic groove, which is also developing. So from the eye, it gradually goes on towards the naso-optic groove. And as you can see over here, the ectodermal, the entire naso-optic groove becomes just a cord of the ectoderm, like this. So over here, the ectodermal cord starts differentiating by the 8th week. So 8th week is when I actually say that the nasolacrimal duct starts developing. And this is a solid strand of the surface epithelium. And you can see that this component is the one which is eventually going to become the lacrimal sac. And these are the two buds which are heading towards becoming the canaliculi. By 8 to 9 weeks, they start growing towards the eye, and the eye automatically impinges into the canalicular ectodermal cord. And this is when the disintegration begins. So you can put it across as 8 to 9 weeks is the time when the canalicular disintegration starts. And it goes on from 10 to 11 to 12 weeks. And eventually, it becomes this way. So when on disintegration, it forms a complete canaliculization. And as you can see over here, that the canaliculus, the entire nasolacrimal duct actually lies slightly lateral to the inferior meatus. Eventually, they start growing towards each other and they start connecting. As you can see over here, this is the final development. As you can see that the inferior canaliculus is slightly lateral to the superior canaliculus. Why does that happen? Because the maxillary process tends to grow more towards the frontonasal process than the frontonasal process. And therefore, the inferior meatus is always slightly lateral to the superior meatus. So it's important to, at this stage, to know about the anomalies, right? So primary punctal disorders would be punctal agenesis, incomplete punctal canalization, punctal stenosis, supernumerary puncta, ectopic punctum, and canalicular wall dysgenesis. So when you're talking about embryology and anatomy and physiology, it's important for you to be able to write down about the possible pathologies that can happen, or the possible congenital anatomical derangements that can occur at every step. And the secondary punctal disorders, which can happen in the cases as peripunctal disorders, punctal trauma, punctal ectropion, iatrogenic punctal disorders, and contiguous punctal involvement in various systemic disorders. So we will be taking up the primary punctal disorders over here. And one by one is punctal agenesis. As you can see that the first 4 steps have gone well, but the 6th, 7th, and 8th step have not occurred in this patient. So this causes basically punctal agenesis. So the puncta eventually is not able to form and connect to the conjunctival epithelium. And it can also occur when the 6 steps have already taken shape. But sometimes in some patients, canalicular agenesis and NLD obstruction are along with punctal agenesis. That is when only the first 4 have occurred. And you can also see that the lashes over here are extending till the canaliculus, till the caruncle. That means that they've gone beyond the pars lacrimalis and they've gone towards the caruncle. The presence of the lashes till the caruncle are an indication of an underlying canalicular agenesis. It could be unilateral, or it can even be bilateral in some of the cases. Punctal stenosis has various types. This is one of the types that is membranous. So when the puncta starts forming and it starts connecting with the conjunctival epithelium, there is a small membrane, that is the membrane of the conjunctival epithelium, which should disintegrate at term. But in these patients, it does not disintegrate at term. It could also be slit-shaped or even horseshoe-shaped, and it's one of the rare anomalies, and or a pinpoint punctal stenosis. And it is also important to do a clinical grading. So clinical grading of punctal stenosis, it's important that if you guys get this right, so it will be easier and more helpful for you to document in your papers. So clinical grade 1 is when it's a stenosed punctum, but it is easily dilatable. Or when it is not easily dilatable, but yes, it's a stenosed punctum. Or when it's a stenosed punctum with a shallow papilla, or it's a stenosed punctum with a flat papilla. So it's important for us to understand that all these 4 grades can occur. Also, Kashkali gave a grading of punctal stenosis, which is called the Kashkali score. And I know it's difficult to learn all of these things, but if you're able to grasp even this in your paper and you're able to memorize and write it, it's going to give you additional points. So grade 0 is when there is punctal agenesis or no punctum formation. 1 is, as we saw in the picture, papilla covered with membrane. 2 is when it is less than normal size and not recognizable. 3 is normal. And 4 is small slit less than 2 mm. And 5 is large slit. It should be more than 2 mm. Or supernumerary puncta can also occur. This is when the bud component is attaching twice towards with the conjunctival epithelium. So there are two buds arising from the inferior bud or the superior bud, and they open as supernumerary puncta. So this was embryology component, and when you get a question about embryology, what would you write? I think you would draw diagrams. I've tried to make clear diagrams for you all, which are easily replicatable in the exams. So you can try taking a look at this, try practicing them. I know we don't have, some of the colleges do not allow color shading, but you can try your hand at this. It's not that difficult. Try to write the embryological weeks and dimensions for all. If possible, try even giving the CRL values. It is difficult to remember, but good to add on. The clinical aspects, either go chronologically or go superior to inferior, whatever suits you. But yes, clinical aspects are mandatory when you have a question on embryology. Additional marks will be when you add the final anatomy with dimensions, if you get time. But yes, it fetches you marks, but you should be able to do that. And ultra additional marks are when you can remark about the surgical interventions to each and every single pathology, which shall be covered eventually in the next few lectures. So I have not highlighted those, but yes, you can keep those in mind. So coming to anatomy, anatomy section is quite extensive and important as well. So in the anatomy, what you need to remember is the lacrimal fossa. So this is the lacrimal gland fossa. This is not the lacrimal gland fossa. So often people get confused with lacrimal fossa, just like I did. And that is, there are two types. One is lacrimal sac fossa and one is lacrimal gland fossa. Lacrimal gland fossa is the one which is in the superior orbital lateral rim. And this is the lacrimal sac fossa. The anterior lacrimal crest on the frontal process of the maxillary bone draws the anterior extent, and it is important landmark during DCR because the anterior limb of the medial canthus attaches over here. So when we are going for a DCR, it is important for us to be able to dissect it off the anterior lacrimal crest in a meticulous and careful manner. And the posterior extent is posterior lacrimal crest on the lacrimal bone. Also remember lamina pepracia. So these are the important clinical pearls which I'm trying to highlight so that you can remember them and put them together. So these clinical pearls will keep popping up throughout the presentation. So lamina pepracia over here is the ideal site of osteotomy during DCR because it is the thinnest site. And also remember that in Asians, the maxillary lacrimal suture is posterior and therefore it might be thicker. So DCR entrance might require thinning out with birth. So it has been documented in some of the papers, and that's why I've tried to highlight that. So this is the one for the ultra additional marks that you can add. Now, highlighting the lacrimal sac fossa. So this is the vertical extent. So it's important for you to remember the osteology landmarks and the osteology extents. The vertical extent basically is 14 to 16 mm. The width is 2 to 4 mm. And the anterior-posterior extent is 4 to 8 mm. And these are basically the air cells, the agar nasi cells, which are present basically medial to the extent of the lacrimal sac fossa. And lacrimal sac may be opened into the ethmoid sinus instead of bone when you're doing a DCR. And that is when you're trying to enter the agar nasi cells. And this is the sutura notha, which is quite important, and I'll explain how. So sutura notha is basically the vascular groove from where the twigs of infraorbital artery pass. And it is important to note that this should be kept in mind when you're doing a DCR because you don't want the patient to be bleeding. And it's also called the sutura longitudinalis imperfecta of Weber. So you anticipate during lacrimal surgery to avoid bleeding. This is the clinical part on this slide. And also remember the ethmoidal foramina posterior. That is the bony dissection above the frontoethmoidal suture can lead to a dural exposure. So you have to be careful about the extent to which you can do the DCR. And the posterior ethmoid foramina, the branches of ophthalmic artery and nasociliary nerve are the ones which are passing over here. So it's important for you to know the extent. So it is 24 mm from the anterior lacrimal crest and 36 mm from the posterior lacrimal crest. So it's important to keep these pearls in mind when you're going for a DCR procedure. Next is the extent and the measurements. So as I said, the numbers are quite important and difficult to remember. So remember that every canaliculus has two parts, a vertical part and a horizontal part. The vertical part is usually 2 mm, that is fixed in superior and inferior both, but the canaliculus is 8 mm inferior and around 7 to 8 mm superior. So the upper punctum length would be 4.5 to 6 mm, and just add 1 mm to it, and that would make the lower punctum, that is 5.5 to 6.5 mm. It's actually important to know these numbers. I wouldn't say that it is not. So the vertical part and the canalicular part you must know and you must highlight. So this is the part which is called the lacrimal papilla. So this is the elevation where the punctal opening forms, and it is the junction of the ciliary and the lacrimal portion of the lid margin. And the direction of this is basically in the upper punctum, it is basically downwards and backwards, and in the lower punctum, it is upwards and backwards. This question is often asked, and often in vivas also, we'll end up getting confused because of the directions, and directions are what the examiners pick on. So this is an important slide, and it is taken directly from Dutton, so it's important and easy for you to visualize. So as you can see over here, that the superior ampulla, that is the ampulla of the canaliculus, is going inwards into the superior pretarsal orbicularis muscle, and it's taking a turn, and then it is joining the medial canthal ligament. And similarly, the inferior punctum, inferior canaliculus is also going and traveling at an angle, which I will be explaining later, and coming to the medial canthal ligament, and it's forming together and joining laterally. And you can also see that all of this lies in the superior preseptal orbicularis muscle, and superior and inferior. So as you can see that these are the puncta, then it's important to also know that the inferior border of the medial canthal ligament is actually the weakest mechanical portion of the sac. And this is the part where the patients are most vulnerable to fistula development. So this is basically a layer gone out, and you can see this, the lacrimal fascia, which can be highlighted, and how the canaliculi are perfectly sandwiched in the lacrimal fascia superiorly and inferiorly. And as you can see now that the posterior muscle is visualized, and that makes the Horner's muscle. So the superior muscle of Riolan and the Horner's muscle, they make the posterior aspect, and the two canaliculi join and make the common canaliculus, which joins at the lacrimal sac. And this is the segment where it is cut, and you can see over here, this is the sac of Meyer, which is formed. So this is the lacrimal sinus of Meyer. And this entire thing is basically 2.5 from the apex of the lacrimal sac, as I highlighted. Over here, you can see that this is the posterior arm of the medial canthal ligament, which can be highlighted, which was not visualized earlier. And this is the DCR landmark. The DCR landmark is actually important when you should know that it is the uppermost border of the medial canthal ligament. So you should know where exactly you need to go in the lacrimal sac. As I mentioned about the angulation, the canaliculi to the common canaliculus, the angle is 57 to 65 degrees, and it is usually this in 90 to 94% individuals. And it goes beyond, and the common canaliculus attaches to the lacrimal sac at a 58 to 90 degree. It depends, it varies. And in Asians also, it is considered it is more perpendicular. And you can also see that the sac actually enters at a 15 to 30 degree angle and lateral to the frontal plane. So common canaliculus to the lacrimal sac angle, if it is increased, then the patients are more susceptible to dacryocystitis. So that is the pearl that you carry from this slide. And another one is that when you are doing syringing, you need to understand this angulation, and you need to pull the canaliculus laterally and change the angulation to avoid further scarring or scarring in future for the patient. So you have to keep all these things in mind. Now coming to the histology, this arrow has actually moved, but it is through the canaliculus. And this is the part where you can see that the epithelium is basically stratified squamous, and it is more than 10 layers. And the next layer that comes within the canaliculus is corium, or the elastic tissue. And the next is the pars lacrimalis, which are the fibers around the corium. And this is what helps. The corium is basically what helps and makes it easy for us to be able to dilate the punctum from 1 mm to go beyond 2 to 3 mm to be able to pass our probes. Now coming to the lacrimal sac. The lacrimal sac has a fundus and a body. And the fundus is 3 to 5 mm and the body is 10 mm. Important to note that, again, make it double, 5 and 10, easy to go that way. And then the nasal lacrimal duct has two components, which is the intraosseous part and the meatal part. The intraosseous part is 12 mm, make it half again, nearly, that is 5 mm of meatal part. No one's going to really stop you and ask you about, like, get the numbers right. So it's okay for you to be able to understand them, like, at an average basis. So it's 5, 10, 10, 5, that's also okay. But try to make the intraosseous part 12 mm. And the next part that you need to importantly remember are the bony landmarks around the lacrimal sac, and that is the lacrimal bone. So medial to the lacrimal sac, you will be able to see the lacrimal bone nicely encasing it. And inferiorly, there is inferior turbinate next to the nasolacrimal duct. And always remember that the nasolacrimal duct opens in the inferior meatus. It's a question very often asked, and very often people get confused. I wonder why. But yes, it's important. It's also important to take this clinical pearl home, that is that in size, the nasolacrimal duct in females is thinner or lesser in size or smaller than the males, and therefore there is higher predisposition in females to NLD obstruction. And the NLD direction, very often asked every time, whether you're a postgraduate or an undergraduate or even a fellow, this question is going to follow you always. And that is that what is the direction? And I think I put a mnemonic there, and that is DPL. So go for downward, posterior, and lateral, not to forget it. So it's actually inferior, but for the then you can make it IPL for that sake. But it's downwards, posterior, and lateral. And the valves of nasolacrimal duct. This is quite important for you to be able to visualize. Just give me 1 second. Hold on. Just give me 1 second. I'll reshare the slides.
Sure, Rolika.
Okay, so my slides are back. Right?
Yeah.
Super, you can see my slides?
Yes, Rolika.
Okay, perfect. So the valves of nasolacrimal system, I have put a QR code over here because this is a QR code of the paper, which is very well written. And I think this is the one paper that I could find after searching a lot. And that is the only one paper which highlights the eponyms of the valves of nasolacrimal system. And this is a very important and often asked question. So yes, the valves are basically the false valves, and they're 8 in number. It's always 7 plus 1, so it's 8 in number. They're basically formed because of a mound of mucosa. So they're not really real valves, they're just mound of mucosa put together. 3 names, if you can remember and put together, because I know that this kind of comes as a question to write for, like sometimes even a short question or even a long question in some of the colleges. So yes, 3 names that you can remember are Aubert, Tucker, and Paulson. So Aubert is the one who first came up with the idea in 1908 about the valves of nasolacrimal duct. And Tucker in 1996 kind of gave affirmation to it and performed even a a DCG. And then he was able to highlight and enumerate each and every valve. So the eponyms were given. And Paulson in 2003 verified the same, but also in Paulson was the one who, on the basis of DCG, kind of questioned them. He questioned and said that these are technically not valves. They're not even helping in any sort of drainage. So let's call all of these valves of nasolacrimal system as false valves. And the names were first valve that you can see over here, that is at the level of canaliculus, is valve of Bogdalic. I'm sorry if I pronounce any of the names incorrectly. I actually tried to get the right pronunciation, but I'm sure that I will fail at it. The second is valve of Folds, and the third is the valve of Rosenmuller or the valve of Hushke. As you can see over here, it basically is the superior and the inferior combined together. And the fifth is the valve of Aubert, and the sixth is the valve of Cross or Bayrod, and it's Bayrod actually. And the sixth is the seventh valve actually is the valve of Tail Effer, and eighth is the valve of Hassner, Horner, Carvela, and Bianchi. I don't know why, but there are four names which are dedicated to this particular eighth valve. And there are other valves as well. That is the valve of Heinlein and Hertel and valve of Wick, which if you can remember, you can go ahead and write in your papers. But the 7 and plus 1, the 8 valves are more than enough. And the QR code is right there. You can take a picture and go ahead and read the paper. In the paper, it's actually even highlighted each and every person's personality and the reason why the valve is called so. And clinically, talking about the clinical pulse, the valve of Rosenmuller is the basic functional barrier to reflux from the lacrimal sac to the conch fornix. So that's what it is considered. And the valve of Hassner is considered as the one which prevents the regurgitation of fluid from nose to the lacrimal duct. So this is what the clinical pulse for valve of Hassner are. Now the NLD variations in the congenital NLDO. So this is important, and it's something which I couldn't really figure out the pictures to, but NLD does not open into the inferior meatus and ends abruptly into the vault of the meatus or gets buried in the lateral wall. That is type 1 or the variation 1. The second variation, it could be that it ends blindly into the inferior turbinate or ends blindly into the medial maxillary sinus wall instead of going to the inferior. And it ends in a bony, non-canalized nasolacrimal duct canal. So, or the absent NLD. So this in itself is a basic clinical pearl. If you're able to put together the nasolacrimal duct, the variations in the congenital NLDO, you will be able to highlight this as well. This was another interesting paper which shows the different types of morphological classification of NLD. Again, an additional ultra high mark pointer for all of you, and that would be the first one is when it is cylindrical in shape. It's cylindrical and going all the way, which is probably the normal one. The second one is when it is called the upper thicker. Sorry, second is the lower thicker, and the third is the upper thicker, and the D is the spindle shaped, and E is the hourglass shaped. So these morphological classifications, if you can actually just draw a linear diagram, you will be able to put these together. Now going to histology of the lacrimal sac. So the lacrimal sac basically is composed of fibroelastic tissue. And there are two layers of columnar cells which can be seen in the cross section, and it also has goblet cells. So you need to understand that over here, they're not yet the cilia have developed. So motility component is not really there. So it's only the fibroelastic component which is taking care of the movement. And this is when we go down all the way, and this is when we're talking about the nasolacrimal duct, which is lined by, again, two layers of columnar epithelium, few ciliated cells, not much. So the valves are technically supposed to be working and helping, and that's how we go around it. So the arterial supply is quite important and difficult to understand. And I do understand that it's like highly miniature vessels around here, but let's try to figure it out. The first branch which helps over here in forming the vascular arcade is the medial palpable branch of the ophthalmic artery. The second is that we also have contributory branches of the facial artery and the infraorbital branch of the maxillary artery. And together they land up supplying the lacrimal sac, the nasolacrimal duct, and the area around it. And you should keep these in mind while you're proceeding with any DCR, because if you have the vascular supply in mind, you know that you can have a bloodless DCR there. And also, yes, the sphenopalatine arteries of the maxillary artery also contribute in the arterial supply. Next comes the venous supply. Venous supply is actually the one which is more problem causing in these DCR surgeries, and that is the angular vein, which is basic union of the supratrochlear vein and the supraorbital vein, and not the infra. So the venous plexus also, there's also venous plexus contributing to the venous supply, which lies in the walls of the lacrimal sac, the nasolacrimal duct, and the nasal mucous membrane. So it travels the same way from top to bottom. And you can also imagine that the sac is tightly adherent to the periosteum right there. So it's not really much of a vascular supply between them, but yes, it's within the walls as well. And what's the clinical pearl here? The angular vein, which passes 8 mm medial to the medial canthus. So moving on to the nerve supply, often forgotten, often confusing, and that is that the one which supplies to this segment is the infratrochlear branch of the ophthalmic division of the trigeminal nerve. Do not get confused. It's not the supratrochlear which is coming towards this side. Supratrochlear goes and angulates to the orbital rim and goes up. But it's all about the infratrochlear which goes down and supplies to the lacrimal sac and also the lacrimal duct. But the lacrimal duct is mostly supplied by the anterior superior alveolar nerve, or which is the branch of the maxillary division of the trigeminal nerve. So you can see over here, there's a picture which is highlighting how the anterior superior alveolar nerve and the inferior orbital nerve are both present, and they're the ones which are supplying the lacrimal duct or the opening of the lacrimal duct. So this is the anatomy. Again, the pointers that we have to take home with us in anatomy would be the diagrams. Try to make it simple. I would just pause for a moment and just tell you one thing is that try not to have too much text in your answers. Try not to have too many like paragraphs. Honestly, nobody reads it. So one examiner will get maximum 3 to 4 minutes or 5 minutes to check your paper. So the more diagrams you make, the more you're kind of making it easy for the examiner as well. And I think the examiners like that. So if you just highlight with diagrams and just put arrow pointers and write your description, that's all that they're looking for. You can even draw one skull picture and draw the anatomical, the boundaries, and then eventually in the same diagram highlight the pathologies, and still you will be fine. You don't think that you're going to write less, you're actually written more than you could. It takes time. Please write the dimensions for all the segments. It is really not a light thing, it's important. If I can just revise once again, that would be 2 8, and then it would be 2 5 12 5. So it's easy, 5 10 12 5. So it's easy to remember that way. So do not mess with the dimensions. It's important to remember them. Try to keep the order superior to inferior, anterior to posterior. Every examiner prefers that because when you are highlighting any of the pathologies, it's easy to traverse in the same direction and it's easy to remember also. Add histology. Try to make a small mini diagram on the side. Even if you're writing about columnar cells right there, just draw 2 columnar cells and a nucleus in it, and they will be really happy about it because it just marks that you have understood the point and you have understood what exactly the different segments are made of. Add the vascular supply and the nerve supply. This is really not optional. This is quite mandatory, and also highlight the clinical pearl as we have discussed over here of how the angular artery is important. Again, I recall it is 8 mm from the medial canthal ligament. So it's important for you to highlight that in a DCR surgery, it's important for the landmarks to be known. Additional marks, clinical pearls, surgical aspects. In anatomy, you just focus on the surgical aspects. If you're able to write them in all of your answers, even if you write a 3-page answer, it's going to be fine, and it takes more time to write it. Ultra additional marks are if you can give the significant pathologies, not really that important, but if you are able to, then great. And I would say the ultra additional part is if you can add the embryology as well. So, as in embryology, we added the anatomy part. In anatomy, it's good to add the embryology part because it's good to show that where it eventually came from. Takes nearly just like 3 to 4 minutes, and I think you can put it all together. Now, coming to the physiology part, physiology is basically important for us to know because that's when the entire drainage component comes in. I would have been quite interested in putting up the excretory component as well, but we all know that the excretory component is from the lacrimal gland, and the physiology is quite detailed and important. And therefore, you can see over here there is a tear duct formation. I've tried to keep these diagrams simple for you all, and I've drawn them so that you can actually modify them and take them home easy peasy. And this is when the eye is open, and that is when the lacrimal, the tear duct is, sorry, the tear film can be seen inferiorly. And when the eye closes, that is when the pump mechanism takes place and the tear gets collected in the lacrimal sac. And then again, when the eye is open back, then the tear is drained into the nasal lacrimal duct and therefore in the nose. So this is important, but again, a flow chart is quite important. So when the tears are formed, I'll just go through this very slowly for you are able to understand and memorize it. So when the tear is formed from the lacrimal glands, it travels across the ocular surface. There is a component which is also important for you to know about the overproduction and underproduction. So if there is overproduction of the lacrimal gland, there's going to be more tearing, and if at all there is less evaporation from the ocular surface, again, there's going to be over drainage. So the tears travel across the ocular surface, they flow along the upper and the lower eyelid margin. Now, some of the aqueous component of the tear film is lost by evaporation, as I said. The rest of it pools in the lacrimal lake, medial to the lower puncta. As you can see over here, the lacrimal lake is forming and eventually it's getting collected medially, and the tears are drawn into the upper and the lower canaliculi and then into the lacrimal sac. How does this process occur? So it's good for you to highlight the eyes open, eyes closed component. So when the eyes are open, the canaliculi and the sac are expanding and they're creating a negative pressure. As you can see in the first picture, they're basically expanding and creating a pressure. I have tried to compress it in the second picture, but I don't think it's that evident because I think I blew up the pictures a little bit. But the tears are drawn into the upper and the lower canaliculi and then to the lacrimal sac. Then this is when the eyes close with a blink. Now, two components work over here. One is the lacrimal part of the orbicularis oculi contracts. When the lacrimal part of the orbicularis oculi contracts superiorly and inferiorly, it creates a positive pressure. And then the tears are forced down the nasolacrimal duct and into the nose via the inferior meatus. Also, there is a pretarsal orbicularis oculi muscle component, which when contracts causes compression on the ampulla. And this shortens and compresses the horizontal canaliculus and then closes the puncta. And this resists the reflux of tears. So with all of these things playing in, you will be able to put together the physiology. What I suggest is just keep a picture of this, keep practicing it again and again, and you're good to go in terms of physiology. So this was the physiology component, and again, important to have diagrams. Always start with basic anatomy, not very detailed, just a basic anatomy. That would be good and good to highlight that way. Diagrams are quite important. Have a flow chart please, and that's all that you need for physiology. I remember drawing just the flow chart and nothing else in my papers. Clinical aspects are important. Additional marks again for the clinical pearls. And thank you so much for that. And that was all for anatomy, embryology, and physiology. I think I've finished well ahead of time. So if you guys would like to discuss anything, I'll be more than happy. If you want me to highlight something again, I can bring up those slides again.
Thank you so very much, Rolika, for such a lucid presentation. However, we would request that can we just go back to those slides where you showed the congenital nasal lacrimal duct obstruction and its variations, the diagrams and all that? And can you
Which part
please
do you want me to show?
the diagrams
The
related to
first.
the first ones which you showed regarding to the CNLDO, the variations.
Okay.
Yeah.
Yeah, I think I went a little quickly apart over there, so I can just take it from there again. So this is the part that I'm kind of going a little forward and coming back to it. So the important part is here, that is the 8 weeks. That is when the ectodermal cord is formed. So this is basically accumulation of the ectoderm. So the two components which I mentioned, the maxillary process and the frontonasal process, are basically mesenchymal in origin, and the rest of it, when accumulates, the entire lacrimal drainage system develops from the ectoderm. So here it forms a condylom, and then the solid strand of surface epithelium, and yes, the buds. So the superior part is when the buds are reforming and they're going to join the conjunctival epithelium. So another interesting thing is that when these are growing, so the epithelium of this growing ectoderm cord and the conjunctival epithelium, when they attach to each other, they stay like that till term. And that is when the baby is born at term, is when that membrane breaks. So often you can see that in the newborns, sometimes there is tearing, and which goes by the next few weeks, and that happens because of the membrane blockage as well. So here the canalization is occurring, and the canalization goes proximally as well as distally. So the canalization actually begins in the center, and it goes proximally towards the medial part of the eye, and distally towards the growing inferior turbinate. And you can see over here that the inferior turbinate is the pink one, which I've highlighted, that is coming from this is the inferior meatus, and the inferior turbinate is forming right there. And that is when the complete canalization has occurred. And I've tried to mark it a little bit more, that the inferior meatus is way beyond the superior meatus, as you can see here, and that the reason to remember is that the maxillary process grows faster and more rapidly and superior towards the frontonasal process, and that is why it's slightly lateral. And what you wanted me to highlight, I guess, were these pathologies. Am I right?
Yes, Rolika.
Okay. So in these pathologies, I'll take them one by one again. Yeah. So this is the pathology which shows punctal agenesis. And that is when the lower puncta over here, which can be seen, has not been able to join with the conjunctival epithelium. And therefore, you can see there is no punctal formation. However, there is a small mound of lacrimal papillae which is forming, but not completely. So, Subha, would you want to try and say that which category, which grading does it come to?
Uh, I can't
It's
see the exact grade though. Like,
okay. We can go forward and we can take it again.
yeah.
So here we need to remember that often the punctal, the canalicular, and the nasolacrimal duct formation are synced together. So if a patient has punctal agenesis, it's a very high possibility that they will have canalicular agenesis and nasolacrimal duct obstruction as well. And that is because the development has somewhere stopped by the seventh to eighth week, and after that the canalization has not occurred. And as I again highlighted over here, that the lashes, when they extend beyond the pars lacrimalis and go towards the canaliculus, that is an indication that there is a possibility of an underlying agenesis. The types that you wanted me to highlight were punctal stenosis, which were membranous. As I mentioned, that the membrane doesn't break. So over here, there's just a membranous one. This indicates that the canalicular segment, the sac segment, and the nasolacrimal duct segment are actually patent, but only the punctal stenosis part is only the puncta is stenosed with a membranous component. And over here, it is slit shaped and horseshoe shaped, which is more of everted, and a pinpoint punctal stenosis. And this is the grade 1. Again, this is stenosed but easily dilatable. Most of the membranous types are grade 1 because they're stenosed and very easily dilatable because there is an internal component which is patent. And this is the stenosed punctum, not easily dilatable. Here, there is a shallow papilla and there is absent papilla. So that is a flat papilla. So these are the 4 variations which are to be kept in mind. And so yes, this is the Kashkali score. You can take a look at it again, and that's important for you to be able to put together in your exams.
The second question we have from the audience is they have requested for the clinical importance of Sucharanatha while operating a case of DCR.
Right. So Sucharanatha is the part where you can have this is the most susceptible component for bleeding. So you need to keep in mind and anticipate the bleeding because that is the vascular groove where the supraorbital artery twigs, they are passing through the Sucharanatha. So if you go towards Sucharanatha, you're gonna be having profuse bleeding, and you really do not want that. So try to stay away from it and keep on.
And a third question is like, what are the landmarks for osteotomy in a DCR?
So I actually asked sir if you would like me to highlight that as well, but he wants to cover it later. So I've kept that aside because he specifically told me not to mention it because he wants to highlight it his way.
All right, yeah. Then one of the students has asked about reproducibility of these diagrams in their exams and how to time while writing their long answer questions.
Well, so these are, I've tried to keep them very linear. I've tried to keep them very, easy to draw. You can actually practice them 2-3 times. The presentation is available, so you can actually keep screenshots in your phones and then try to practice and draw them out. Trust me, from a person who, this is coming from a person who does not write much in the papers. I prefer drawing. So it's easy when I draw it and I put together. And yes, for some of you, it will not be very easy to put the diagrams together. But even if you draw some linear diagrams which are not exactly representative, nobody is going to judge you on your artistic skills. So what they need is a basic understanding of the subject. So whenever the consultants or any professors are checking your papers, they're just looking at what is your basic understanding and if you've marked the correct segment correctly. So if you're marking the medial eminence and the lateral eminence, and if you have highlighted it correctly, that's good enough. If you have colors, then it's easier for you to be able to tell it in a chronological order of how it's growing and how the particular segment is changing, of how the naso-optic groove became eventually the nasolacrimal duct. The way you can show that, it would be great, but colors if not allowed, then you can go ahead with the diagrams. Easily reproducible. Otherwise, just draw an eye and just draw in the physiology part, just draw an eye, a blue line, and just show the tear growing there. Put arrows, that's also fine. Just anything, just don't start writing, because if you're an examiner going to check a paper, you will not be reading everything.
Yeah, very true. One of the students has asked, can you please opine again on supernumerary puncta?
Supernumerary puncta. So basically, supernumerary puncta are when you saw the budding component, right? So when the buds are formed for the superior and the lower canaliculus, at times there are two buds which are formed from the same bud. So that means that it is one going up, one going down, and now the one which is the the future congenital anomaly divides into two, and then it opens in two different segments um, in the eye. So that forms the supernumerary puncta. So there are two buds opening as two puncta.
Okay. The next question is, can you please explain about the angulation change in cases of dacryocystitis as once enumerated in one of the diagrams?
Okay, sure. So the angulations that I mentioned were basically the two common canaliculi, or the canaliculi to the common canaliculus angle is approximately 57 to 65 degrees, which occurs in majority of the cases. And the next angle that is important is common canaliculus to the lacrimal sac, which is 58 to 90 degree. It's actually moreover like an acute angle, but yes, in the cases with in Asians, or in like in the more interpalpable fissure, intercanthal distance, that is when the angle increases to 90 degree. And then the sac enters uh, at 15 to, like, the entry where the common canaliculus enters the sac is at 15 to 30 degrees of angle, and it is slightly lateral to the frontal plane. So what I mean to highlight is that the common canaliculus to the lacrimal sac, that angle, if it increases, the susceptibility to dacryocystitis increases because there is a stasis and because of the lack of angulation. And that's what we mean by that.
All right. For the benefit of the postgraduate students, could you please once again explain what are the do's and don'ts while performing syringing as an office procedure?
Sure. That's a very good question. In fact, very often it is like incorrectly performed. So I would just begin from scratch. So when you're taking the patient in room, just make sure that you have oriented the patient about what you're going to be doing. It's good to educate them because often it is a painful procedure. So it's good for them to know what are the steps that you will be following. Please maintain hygiene. Please maintain hygiene for yourself and for the patient as well, specifically in the COVID era. So when you make the patient lie down, try to make them lie down in either at 45 degrees or all the way to 90 degrees, whatever you're convenient with, but that should give a good visualization to you. And make sure that the patient is well anesthetized. So make sure that you put instilled drops, which are not, and keep a gap. So don't be like, okay, we have put the drops and let's go for the procedure. You can repeat the drop 2-3 times and give it some time. And when you are performing the syringing, when you're doing the probing, so at the time of probing, just make sure that you're pulling the meatus laterally. That obliterates the angle. If you are not doing that, then what happens is that you're causing an inadvertent scarring, which is going to cause further fibrosis for the patient. So instead of really helping out, you're causing more trouble. So when you're doing the probing, that time just make sure that you go inferior. If you're talking about the inferior punctum, so go inferior and pull the meatus laterally, and then bend it down towards your towards the lateral side and push medially. That is when you will be hitting it. So it's important for you to know whether it's going to be a hard stop or a soft stop, because that indicates the level of your obstruction. I also wanted to highlight the sites of obstruction, but then again, it was mentioned that it will be taken again in the next few segments. So if you're getting a soft stop, that means you're hitting somewhere the canaliculus. So it could either be a canalicular block or a common canalicular block. So if you are getting shorter, that means, as I said, it's 2 and 8. So if you're getting less than 10 mm and somewhere within it, it's good to measure it. So when you're putting your Bowman's probe, just take it out, measure it by scale, and just see, or with a caliper, and just see that how far have you gone. So if at all you are like say within 5 to 6 mm, that means that it's a isolated canalicular block that you are dealing with. If at all you've gone all the way and you're still getting a soft stop, it could be that you're hitting the common canalicular block. And if you're hitting you're getting a bony hit or a hard stop, that means that there is no soft block. So that's when you know you're aware of it. Any other
Hi,
additional
Rolika.
points?
I
Yeah.
think that
Ritik.
your presentation was really, really good. And I think you've given a lot of helpful tips for the postgraduate students, especially from the exam point of view. To this person, I think you've covered everything. I'd just like to add that, in the OPD, when you're performing this, avoid using needles. You can use a proper cannula to do the syringing. It should be a straight tipped blunt cannula. And as far as possible, try doing it from the upper punctum, unless you obviously cannot, do it through the lower one. It kind of reduces any sort of injury to the lower punctum. And as she mentioned, good anesthesia makes this, it really is not a painful procedure. So it shouldn't be painful at all. So that anesthesia is actually helpful in that regard.
Yeah. And also to add that, as she mentioned, that it should be a straight one. Very often it is misunderstood that it's a bent cannula, which is better, but it's actually the straight one. The bent one can cause more scarring. And also try to avoid doing any type of syringing in patients with dacryocystitis. It is really not the correct thing to do. And if you think that you got a regurgitation and you're happy about it, well, you have done something wrong. So try to be very practical about doing a Roplas before you go in for a syringing. So the first and primary step would be make sure that you press it right and get it right.
At this point, may I invite Dr. Britika to have some expert comments on today's talk?
I think she covered this topic beautifully. And I don't have anything else, any other points to add. I think the students also asked quite, interesting questions to kind of elaborate on the topic. So good that they're listening in and enjoying these lectures.
Well, a
Thanks,
disclaimer,
Rolika.
this was not a very easy and convenient topic.
Yeah, it was not. But your presentation is going to be really helpful for all the students.
I hope it helps. Okay. Thank you, everyone.
Yeah. I think the presentation, as always, like every time Rolika presents, it's like a avenue which opens up, like something new, something very vibrant. And it is like all these animations and all that, transitions and all that are so beautifully even taught to us by her. So it is a visual treat for all the students. And I'm sure when they watch it over the weekend, they'll have a pleasure doing so. And it will be really, really helpful during their examinations to prepare from this. It will be a one-stop for all the lacrimal system anatomy and embryology and physiology at the same time. Thank you so very much with those words. And before we conclude for today, I have a small announcement to make.
Should I do that on Subha's behalf?
I can do that. I'll do that. Okay. We meet next on the 11th of October, and the topic being clinical and radiological evaluation of the lacrimal system by Dr. Nandini. Hope to see you all there. Thank you so very much for joining in today, and it was a pleasure having Rolika on the screen and on the platform as well.
Thank you. Enjoy the rest of lacrimal system. It's going to be fun.